Hector suffers from autism, a psychological disorder that involves issues with socializing, communication, and behavior. Hector's mom, Kelly, is worried about what might have caused Hector to be autistic. Was he born that way? Is it because she's a bad mom? Or is there some other explanation for his problem? Psychologists don't always agree on what causes mental illness. Some believe that psychological problems spring from problems in childhood that remain unresolved. Others believe that genetics can explain most mental illnesses. Still others think that psychological disorders are caused by learning bad habits. Physiological psychology is the study of the physical basis of thoughts, behaviors, and feelings. For example, physiological psychology might say that Hector's autism is caused by brain abnormalities, which are caused by some type of biological problem. Many studies have shown that there are brain differences in people with a variety of mental issues. From depression to schizophrenia to autism, many psychological disorders can be traced to abnormalities in the brain. But what causes the neurological anomalies? That's what physiological psychology tries to figure out. Let's look a little closer at some common physiological explanations for mental issues, including viral infections, malnutrition, and metal poisoning. Remember Hector? He's suffering from autism. Kelly, his mom, worries that maybe he's autistic because she's a bad parent. For many years, that was what psychologists believed. Cold and unloving parents could cause their children to become autistic. But brain scans showed that there were neurological abnormalities that caused the autistic symptoms. For the past few decades, then, the question has become, if autism has a neurological basis, what causes the brain anomalies? There are many theories, and scientists don't agree on which theory is correct. One theory with scientific support is the possibility that viral infections during pregnancy or early childhood could change the way the brain develops, causing the symptoms of autism. There are studies that show correlations between viral infections and autism, and studies that show no correlation between the two, so it is impossible to know for sure how strong the link is between the two of them. For other mental illnesses, though, there is a very strong link between infection and mental illness. Schizophrenia, for example, has strong links to pre- and postnatal infections. Though studies can't show that schizophrenia is caused by infection, it is a risk factor for the disease. Likewise, there are connections between obsessive-compulsive disorder and the strep infection. Some children who have had a strep infection develop OCD or OCD-like behaviors. Though there are several mental illnesses that are connected to infection, it is far from the only possible physiological cause of mental illness. Malnutrition can also play a role in development of psychological disorders. Sometimes the malnutrition is in infancy and early childhood, and other times it is linked to maternal malnutrition during pregnancy. Remember Kelly and Hector? Kelly has always been thin and eaten very little. Her mother worried that when Kelly was pregnant, she didn't eat enough food and was missing key nutrients like omega-3 fatty acids and vitamin B. Could this have caused Hector's autism? There are some studies that link nutritional deficiencies to autism. As with infections, though, the evidence for nutritional causes of autism are less strong than for other mental illnesses, including schizophrenia, which is linked with prenatal malnutrition in several studies. Other mental illnesses that might be linked to nutrition include depression and anxiety. Kelly has a friend named Lucy who is very concerned about Hector's autism. Lucy believes that vaccines can cause autism in kids. She's read that vaccines contain mercury, and mercury poisoning can lead to autism. Should Kelly be worried and refuse to continue vaccinating Hector? There are no studies that link vaccinations with autism, despite the prevalence of people who believe that the vaccinations cause the disease. Some parents believe that mercury that was used in vaccines in the 1980s and early 1990s is the reason that autism rates have increased in the past 30 years. However, mercury poisoning presents very differently than autism, and there are no links to mercury poisoning and autism. However, lead poisoning can cause some mental illnesses. Lead is a metal that used to be used in paint. Babies love to put everything they find into their mouths, and when old lead-based paint chips, some children digest it. This can cause many psychological issues. Most common among lead poisoning-based disorders are intellectual disabilities, which used to be called mental retardation. In this disorder, a person's cognitive, or thinking, skills are severely limited. There are strong links between lead poisoning and intellectual disabilities. Physiological psychology studies the way in which physical problems can influence our mental health. Specifically, much of physiological psychology is focused on figuring out what causes brain abnormalities that lead to mental illness. 3 possible explanations are infection, malnutrition, and metal poisoning.
Usually when people come into the early treatment program, they're coming in with psychotic experiences, like hearing things that other people don't hear, or having very unusual and scary thoughts. And so the medicines we prescribe at the early treatment program are designed to target those specific symptoms and help people achieve remission, help those symptoms go away, so that they can go on to achieve their hopes and dreams for themselves and continue to go after their goals in life. There are many different types of antipsychotic medications that we use here at the early treatment program, and the majority of them target the dopamine receptor in the brain. It blocks dopamine, which is thought to be responsible, at least partially, for some of the psychotic experiences that are pretty scary that bring people to the early treatment program. All medications can have potential side effects, and that's something that we monitor very, very closely and take very, very seriously. And my job as a psychiatrist is to make sure that the medicine is helping with the symptoms but not causing any side effects. The best thing that someone can do if they're struggling with some psychotic experiences is to take medication to help those experiences go away. But of course, here at the early treatment program, we let each individual decide for themselves what works best for them in their lives. And there are many young folks that we work with who don't necessarily go on medication right away or at all. Typically, we would recommend that somebody stays on medication for about 6 months to make sure that the symptoms are under control. Some people take medicine for their entire life, just like somebody who would have diabetes or high blood pressure. And sometimes people only need medication for a short moment of time in their life, a few months. It's hard to know initially how long somebody's going to need to be on medicine, but you should work with your doctor to figure out exactly what the right dose is and for how long.
I felt so overwhelmed by everything. As the day went on, the shaking and sweating got worse. As someone asked me what was wrong, I'd start to cry. I couldn't control it. I went to counseling and saw my physician. After a couple weeks with the medication, I had control again and felt so much relief.
I was always on the edge. I was very jumpy and reactive, and I would lose my breath when I talked to people. After a month with therapy and medication, I felt like I could breathe again. I was able to work on some coping techniques that really helped me feel better.
These are the voices of people who have found medication to be an important part of helping them with anxiety. Everyone has experienced some kind of anxiety. Sometimes it's just worry about what other people might think of you, about personal plans, or the future. Other times it feels more like agitation, irritability, or even sadness. Sometimes anxiety can affect more than just how you think or feel. The physical symptoms of anxiety can be overwhelming and feel hard to control. These include rapid breathing and heart rate, sweating, trembling hands and feet, excessive tearfulness, a lump in the throat, problems with digestion, like feeling sick to your stomach, and a constant headache. They often make anxious feelings worse. The experience can feel so bad that a person can dread it happening again, which only increases the worry and can even result in a panic attack. Cognitive behavioral therapy and medication are both effective treatments for symptoms of anxiety, especially when used at the same time. It's important to know a little about the different kinds of medication for anxiety. Selective serotonin reuptake inhibitors, or SSRIs, and serotonin and norepinephrine reuptake inhibitors, or SNRIs, are the most common and effective medications for both anxiety and depression. SSRI and SNRIs are taken daily, are effective for long-term treatment, and help reduce symptoms such as irritability, agitation, frequent crying, and excessive worry. SSRIs or SNRIs are not addictive and do not result in substance use disorder. Benzodiazepines, commonly known as benzos, are fast-acting medications commonly used to treat significant anxiety symptoms and panic attacks. While effective, these medications can be addictive. They should never be taken in combination with alcohol or opioids, and should only be used as directed by a physician. Safe use of benzodiazepines can be effective for anxiety symptoms, but should only be used in close collaboration with a doctor and as part of a larger wellness plan. Beta blockers are a type of medication usually used for high blood pressure or uneven heartbeat. They can also be effective for short-term reduction of anxiety symptoms related to heart rate, sweating, or shakiness. Some specific prescription antihistamines can also be used in a similar short-term manner. These medications can be used on an as-needed basis, especially when specific situations, like flying, impact someone's life. Each class of medication for anxiety has different benefits and risks, and each can offer relief for anxiety symptoms that get in the way of day-to-day life. Most primary care providers are familiar with these medications, which, in combination with cognitive behavioral therapy, are effective treatments for anxiety disorders. Anxiety symptoms can be overwhelming, but with the right treatment, anxiety can be manageable for almost anyone. Physical symptoms can be reduced, and you can learn positive coping strategies for long-term success. People literally breathe easier and learn to feel hope again.
In the 1950s, the discovery of two new drugs sparked what would become a multi-billion-dollar market for antidepressants. Neither drug was intended to treat depression at all. In fact, at the time, many doctors and scientists believed psychotherapy was the only approach to treating depression. The decades-long journey of discovery that followed revolutionized our understanding of depression and raised questions we hadn't considered before. One of those first two antidepressant drugs was iproniazid, which was intended to treat tuberculosis. In a 1952 trial, it not only treated tuberculosis, it also improved the moods of patients who had previously been diagnosed with depression. In 1956, a Swiss clinician observed a similar effect when running a trial for imipramine, a drug for allergic reactions. Both drugs affected a class of neurotransmitters called monoamines. The discovery of these antidepressant drugs gave rise to the chemical imbalance theory, the idea that depression is caused by having insufficient monoamines in the brain's synapses. Iproniazid, imipramine, and other drugs like them were thought to restore that balance by increasing the availability of monoamines in the brain. These drugs targeted several different monoamines, each of which acted on a wide range of receptors in the brain. This often meant a lot of side effects, including headaches, grogginess, and cognitive impairments, including difficulty with memory, thinking, and judgment. Hoping to make the drugs more targeted and reduce side effects, scientists began studying existing antidepressants to figure out which specific monoamines were most associated with improvements in depression. In the 1970s, several different researchers converged on an answer. The most effective antidepressants all seemed to act on one monoamine called serotonin. This discovery led to the production of fluoxetine, or Prozac, in 1988. It was the first of a new class of drugs called selective serotonin reuptake inhibitors, or SSRIs, which block the reabsorption of serotonin, leaving more available in the brain. Prozac worked well and had fewer side effects than older, less targeted antidepressants. The makers of Prozac also worked to market the drug by raising awareness of the dangers of depression to both the public and the medical community. More people came to see depression as a disease caused by mechanisms beyond an individual's control, which reduced the culture of blame and stigmatization surrounding depression, and more people sought help. In the 1990s, the number of people being treated for depression skyrocketed. Psychotherapy and other treatments fell by the wayside, and most people were treated solely with antidepressant drugs. Since then, we've developed a more nuanced view of how to treat depression and of what causes it. Not everyone with depression responds to SSRIs like Prozac. Some respond better to drugs that act on other neurotransmitters. or don't respond to medication at all. For many, a combination of psychotherapy and antidepressant drugs is more effective than either alone. We're also not sure why antidepressants work the way they do. They change monoamine levels within a few hours of taking the medication, but patients usually don't feel the benefit until weeks later. And after they stop taking antidepressants, some patients never experience depression again, while others relapse. We now recognize that we don't know what causes depression or why antidepressants work. The chemical imbalance theory is at best an incomplete explanation. It can't be a coincidence that almost all the antidepressants happen to act on serotonin, but that doesn't mean serotonin deficiency is the cause of depression. If that sounds odd, consider a more straightforward example. Steroid creams can treat rashes caused by poison ivy. The fact that they work doesn't mean steroid deficiency was the cause of the rash. We still have a ways to go in terms of understanding this disease. Fortunately, in the meantime, we have effective tools to treat it.
In this installment, I will discuss selective serotonin reuptake inhibitors, or SSRIs. SSRIs were developed in the 1970s with the goal of treating depression by increasing serotonin levels. This goal was formulated based on the serotonin hypothesis of depression, which suggests that depression is caused by low levels of the neurotransmitter serotonin. SSRIs work by inhibiting a mechanism called reuptake. In reuptake, a protein called a transporter transports excess neurotransmitter molecules out of the synaptic cleft, usually back into the neuron that released them. SSRIs inhibit the reuptake of serotonin. By inhibiting the removal of serotonin from the synaptic cleft, this causes levels of serotonin in the synaptic cleft to rise. These increases in serotonin levels have been hypothesized to be the mechanism by which SSRIs can treat the symptoms of depression. There are reasons now, however, to believe that there must be more to the mechanism of SSRIs than just changing serotonin levels. For example, when someone begins taking an SSRI, they generally have to wait about 4 weeks before their symptoms improve. Evidence suggests, however, that their serotonin levels rise as quickly as within an hour after taking the medication. Thus, it seems likely that SSRIs may affect serotonin levels, which then leads to other effects that influence the symptoms of depression. Therefore, it's probable that more than serotonin levels must be changed for SSRIs to work, which suggests that depression isn't caused only by low serotonin levels. Additionally, evidence has now emerged that questions the effectiveness of SSRIs. Some research has found they do not work much better than placebos, and may only benefit those who are most severely depressed, which is a minority of patients who actually take the drugs.
Honestly, there's nothing clever or funny to say about depression. If you've ever known someone who is depressed or experienced it yourself, you know how hard and all-consuming it can be. The good news is that depression can be treated with therapy and medication, but antidepressants can also be kind of complicated, and there are a lot of misconceptions that only increase the stigma around them. So let's set the record straight. One common misconception is that antidepressants don't actually do anything. But that's not true. They do help. This idea mostly came from a 2008 study published in PLOS Medicine. The study was a meta-analysis, meaning that it analyzed a bunch of other studies, in this case, 47 of them, and looked for a measurable effect across all of their results. It suggested that for people with mild to moderate depression, antidepressants don't work much better than a placebo, a treatment that makes you think you're being treated, but doesn't actually do anything. Instead, the study found that antidepressants work better for people with more severe symptoms. There was another meta-analysis in 2011 that found antidepressants were more effective than placebos in treating mild long-term depression, called dysthymia or persistent depressive disorder. But that didn't stop the controversy around the first study. It turns out that if you didn't look at the methods for that first meta-analysis, it was easy to misinterpret the findings. For one thing, the average length of the treatment in those studies was just 4 to 8 weeks, whereas most people take antidepressants for months. Research subjects were also selected and treated differently than they would be as patients. In real life, a patient and their doctor will work to find the best dose and kind of medicine, because the same medication doesn't work for everyone, especially when it comes to mental illness. But in a study, everyone's given the same prescription. So if you're just looking at whether one antidepressant is better than a placebo if you give it to everybody, then yeah, you'll find it's not that helpful for mild to moderate depression because a bunch of the subjects won't respond well to that particular medication. But that doesn't mean antidepressants as a whole aren't effective, as long as you're taking the right medicine for you. Which brings us to another misconception, that all antidepressants do the same thing, so if one doesn't work for you, none of them will. But that's also not true, because different antidepressants do different things. To understand why, it helps to know a little bit about neuroscience. Your brain is full of neurons, which have tiny gaps between them called synapses. And neurons communicate by sending chemicals called neurotransmitters across synapses to each other. Researchers aren't entirely sure why, but having more neurotransmitters in your synapses seems to ease depression, possibly because it helps your neurons transmit information. So, antidepressants increase the availability of certain neurotransmitters in your brain, but in different ways. Reuptake inhibitors, for example, prevent neurotransmitters from being reabsorbed into neurons, so they stay in the synapse longer. The most common kind are SSRIs, or selective serotonin reuptake inhibitors, which affect the neurotransmitter serotonin. They're the more famous ones, like Prozac and Zoloft. There are other reuptake inhibitors that affect other neurotransmitters, like SNRIs, which work on serotonin and norepinephrine. And there's another class of antidepressant called tricyclics, which also affect the reuptake of serotonin and norepinephrine, but slightly differently than SNRIs do. Then there are antidepressants that work totally differently, like monoamine oxidase inhibitors, which prevent neurotransmitters in the synapse from being broken down. Plus a whole bunch of others that I didn't even mention. So not all antidepressants are identical, and doctors have plenty of options for figuring out what's best for different people. Most of the antidepressants we use these days are really safe, but like a lot of medicines, they still have some side effects. For example, people who start taking SSRIs often experience digestive side effects like constipation, diarrhea, and bloating, which might seem confusing because when you think serotonin, you probably think brain. But that's our third misconception, that antidepressants only affect your brain, because they can affect your gut too. About 95% of your serotonin actually goes to your digestive tract, where it controls smooth muscle function, regulates stomach acid, and controls mucus production. Increasing the amount of serotonin in your brain can lead to a shortage in your gut, which causes those unpleasant symptoms. Antidepressants can have such a big effect on the digestive tract that doctors prescribe them to treat irritable bowel syndrome too. Thankfully, most of these side effects do go away after a few weeks and aren't anything to worry about. It can also take a few weeks, usually 4 to 6, for antidepressants to start working at all. And that's the last misconception on this list, that antidepressants start working right away. It's still unclear why there's this delay. Antidepressants start impacting those neurotransmitters right away, even if you can't feel it. One possibility is that instead of directly improving your mood, the extra neurotransmitters help by gradually affecting the way you process thoughts. The delay might also have to do with other signaling molecules in your cells that could be involved in depression but take longer to respond to the meds. But either way, even if you don't notice a change at first, that doesn't mean the medicine isn't going to work. So there's a lot of misinformation and confusion about antidepressants out there, but for many people, they make a huge difference. So figuring out what's true and what's not is definitely worth it.
We usually think of medicine as intended to cure specific physical symptoms, painkillers to help a headache, antibiotics to cure an infection like strep throat. So how can drugs be designed to affect the mind, achieving specific results like making someone less depressed or getting rid of hallucinations? Like many medicines, the earliest kinds of psychiatric medications were discovered largely by accident. The first antidepressants were intended as treatments for tuberculosis. The first antipsychotics were developed as anesthetics to use during surgery. These medications were found to improve mental functioning by changing brain chemistry in a variety of ways. In general, they change levels of neurotransmitters in the brain. Neurotransmitters are chemicals in the brain that allow brain cells, called neurons, to communicate with each other. Psychologists have noticed that the amounts of certain neurotransmitters in the brains of people with certain disorders are different than in healthy people's brains, leading to the development of drugs that aim to correct these imbalances. Antidepressants change the levels of the neurotransmitters norepinephrine and serotonin, which affect emotion and mood. There are 3 basic kinds of antidepressants, called MAOIs, monoamine oxidase inhibitors, tricyclics, and SSRIs, selective serotonin reuptake inhibitors. They all function a little differently. MAOIs and tricyclics raise both norepinephrine and serotonin levels. SSRIs raise only the levels of serotonin in the brain. This creates fewer side effects than MAOIs or tricyclics, though it does increase sexual side effects like lack of desire and erectile dysfunction. MAOIs have the worst side effects, which is why scientists kept working to make the newer kinds of antidepressants. People who take them must be careful to avoid foods that contain the chemical tyramine. Can you guess what kinds of foods contain tyramine? The best kinds: beer, some cheeses, and cured meats. And if a person messes up and eats these foods anyway, it can produce a fatal interaction with the MAOI. These drugs are usually only recommended to people whose bodies can't tolerate the newer antidepressants. While antidepressants work primarily on norepinephrine and serotonin, antipsychotics work by reducing the activity of a third neurotransmitter called dopamine. Dopamine is the neurotransmitter that regulates pleasure-seeking behavior. You know that rush you get when you get an unexpected reward? Maybe you win at the slot machine, or your boss tells you she's decided to give you a bonus. You feel great because your dopamine levels have spiked. But consistently high levels of dopamine can make you really sensitive to excessive stimulation. And in the case of schizophrenics, this can cause hallucinations and delusions, known as the positive symptoms of schizophrenia. Antipsychotics can help reduce these positive symptoms, called positive not because they are good, but because they are things that are more than what most people experience. Most antipsychotics have little effect on the negative symptoms of schizophrenia, like blunted emotions and loss of pleasure. But a new generation of drugs, called atypical antipsychotics, has been shown to have some effect. All antipsychotics can cause side effects, like drowsiness, tremors, and coordination issues. There is also a very rare, nasty side effect called tardive dyskinesia, which is a permanent neurological condition that causes involuntary movements. This condition persists even after treatment with antipsychotics is stopped. Bipolar disorder is most commonly treated with another type of psychiatric medication called lithium. If that sounds familiar from chemistry, you're right. It's an element on the periodic table, and when it's used to treat psychological disorders, it's given in the form of a salt, or a kind of chemical compound that includes the element. Though it's an effective mood stabilizer, the way it works in the brain is still unclear. Treatment with lithium also requires careful monitoring, since the active dose is only slightly less than a toxic dose. Most medications have a much larger gap between these amounts, making accidental overdoses less common. Lithium has a long history of use as medication. It's believed that the ancient Greeks and Romans used spring water containing lithium to treat manic and depressive disorders. In the early 20th century, lithium was an ingredient in a beverage still consumed today, then marketed as a hangover cure. There's no lithium in it anymore, but the drink is, have you guessed it yet? 7-Up. We've gone over 3 major classes of drugs for 3 disorders: antidepressants for major depression, antipsychotics for schizophrenia, and lithium for bipolar disorders. These all work by altering brain chemistry, though in the case of lithium, the exact mechanism is unknown. These drugs can be really helpful to some patients, though psychologists worry about prescribing them without careful consideration or as a substitute for talk therapy. Since many of the drugs do not keep working after a patient stops treatment, many patients take them for a very long time, and such long-term side effects aren't always known. Given these problems, psychiatric medication should be seen as simply one type of therapy, likely to be used alongside other types, and not a be-all and end-all treatment for psychological disorders.
Hi, my name is Lauren, and in this video I'm going to be talking a little bit more about what exactly ECT or electroconvulsive therapy is, as well as what my experiences with it were like. So electroconvulsive therapy used to be referred to as electroshock therapy, or it was commonly referred to as shock treatment. So basically, electroconvulsive therapy is a treatment done under general anesthesia in which they place small electrodes on your temples in order to pass small electric currents through your brain in order to induce a small seizure. ECT seems to cause changes in the brain chemistry that can seem to reverse the effects of mental illnesses or mental health problems. So ECT has been refined since the days of One Flew Over the Cuckoo Nest, and it doesn't really look like that anymore. However, they still don't really know exactly how it works and what the effects are on the brain. They just know that it's sometimes effective in treating mental health problems. So I'm just going to walk you through what the experience was like for me and to give you a little bit more insight into what exactly ECT entails. So as I mentioned before, ECT is commonly used with treatment-resistant depression, so it's not usually used as a first line of defense in treating a mental health problem. So for me, I had tried a bunch of different medications already for my depression, and I had tried therapy as well, and nothing really seemed to be working. So my doctor suggested that we try electroconvulsive therapy. So I think the first thing that people don't really know about it is it's not just a one-time treatment. So for me, I went and had it done 12 times. So 3 times a week for 4 weeks. So I was pretty scared initially, not really knowing what exactly it was going to entail and what exactly ECT was or what it was going to feel like or what it was going to do in terms of side effects to me. But I went, and so it usually happened first thing in the morning, and there was always a group of us. So there was a mix of some inpatients and some outpatients. I was being treated as an outpatient when I received it. So there was a group of us that went in to get it done at the same time, basically. So outwardly, I was showing that I was calm and I guess composed about the whole situation, which is why they usually put me near the end of the group, which was a little bit problematic because then I could hear and see some of the other people getting the treatment done, which was a little bit traumatic to say the least. So basically what would happen would be that they would set you up with an IV, and then they would attach an electrode to your temple, either on one side or on both sides, depending on which kind of ECT you were receiving. I only had it on the one side, but then they would hook that up, and then going through the line, they would wheel you over to the station where they do the ECT, and they would inject you with a muscle relaxant in order to relax your muscles so that you didn't break any bones or so that you weren't really sore the next day after having the seizure. And then they would put you under with general anesthetic. So they would kind of explain that process to you, and then they would count backwards from 10 as they put the general anesthetic into you, and you would lose consciousness. But because I was near the end of the line, I was still conscious while others were getting their ECT done, so I could hear the seizures and I could kind of see what was going on with the doctors and whatnot. So that was a little bit traumatic, but it helped to kind of understand the process a little bit better as well. So when it was my turn the first time, it was really scary because there was doctors and nurses standing over me, and I had an electrode attached to my temple, and I knew that I was going to be shocked in order to induce a seizure. So the actual treatment was done while I was put under, and so while I was unconscious, they administered the small electric currents into my temple to pass through my brain, and that's when I had the induced seizure, which is what they believe helps to alleviate some mental health symptoms. So the aim of the seizure is to be around anywhere between 30 to 60 seconds. From what I saw and what they told me, it was anywhere between really 20 to 60 seconds. So just to reiterate, you are unconscious during this process and you don't feel any of the electricity passing through you or the seizure or anything like that, and you don't remember it either when you wake up. But basically when I woke up, I was a little disoriented because of being put out and shocked. But I was able to remember where I was and what had happened and whatnot with a little help from the nurses and a little prompting from the nurses. I had a headache and I was sore already. But other than that, it went okay, I think. So it took about an hour to come out of the anesthetic, and I wasn't allowed to drive myself home, obviously, for obvious reasons. As the day progressed, after I got my first treatment, the headache got a bit worse, and I got quite a bit more sore as well, just from the effects of being tense during the seizure. I told the nurses this the next time, and they gave me a little bit more of the muscle relaxant, which did help. And I just took some ibuprofen for the headache. So recovery time after the procedure, they recommended taking the whole day off, but I oftentimes would just shower to get the gel out of my hair from the electrodes and go to school. I probably wouldn't recommend doing this. I'd probably recommend taking a day to just kind of relax and recuperate, but I think it affects everybody a little bit differently. So a lot of people say that it's kind of a gradual lifting of the fog for them when they receive ECT and it's effective. So this is why I kept going back for more treatments, even though it didn't really seem to be helping me at the time. Unfortunately, after the whole course of the ECT treatments, I didn't really feel any effects, and I was really left with memory deficits as well. So it really affected my short-term memory, and to this day, I still have some problems with short-term memory. So because it wasn't effective for me, some people have asked me if I regret getting it, and the simple answer to that is no, I don't, because I was in such a point with my depression at the time and early signs of schizophrenia that I was so desperate for reprieve or desperate for any form of effective treatment that I was willing to really try anything. So no, I don't regret doing it. I wish it had worked, but it didn't. It is a treatment that works for a lot of people, and there are quite a few studies coming out lately that indicate the effectiveness of the treatment. So if you are watching this and thinking about getting ECT, or your doctor has mentioned it to you as a possibility, I just want you to know that it's not as bad as people commonly think it is, and it is effective for some people.
People around the world are strapping batteries to their heads to supercharge their brains. Seriously, this is a thing. It's called transcranial direct current stimulation, or TDCS, and it involves using electric currents to stimulate your brain. The companies that want to sell you TDCS devices claim that it has all kinds of benefits. They might say that it'll boost your memory and focus. Some even claim that it can do everything from treat depression to help you sleep better. If that sounds too good to be true, it is. The truth is a lot more complicated. Studies have found that TDCS might help with some things, but there's also plenty of controversy about it among scientists, and the jury is still out about how exactly TDCS affects the brain. Even though it involves electric currents, TDCS is a lot less intense than the kind of supercharged electric shocks used in electroconvulsive therapy. That's the more famous electricity-related therapy that's sometimes used to treat things like really severe depression. A TDCS headset contains two electrodes called the anode and the cathode. The idea is that the anode will boost the area of the brain beneath it, whereas the cathode will inhibit the area beneath it. The choice of those areas, of course, depends on the particular functions you're looking to play with. Once everything is in place, a small electrical current of around 0.5 to 2.0 milliamps is sent through the electrodes right into your head. Since the current is so small, it's not painful as long as you set it up properly. The most people tend to feel from this kind of current is a mild tingling sensation on their scalp. A TDCS session typically lasts around 20 to 30 minutes, and people usually do a number of sessions over the course of a few weeks. The thing is, most people doing this at home might be making their scalps tingle for nothing, because we still aren't sure if TDCS actually does a lot of the things companies selling these devices are claiming. Entering the world of TDCS experimentation has a pretty low bar since headsets are fairly inexpensive. Unfortunately, that's made the literature a little messy. One problem is that we still aren't totally clear on what TDCS does to the brain on a physiological level. We do know that current can affect the way neurons fire, and researchers think that the mild current from the electrodes changes the membrane potentials of neurons, allowing them to fire more easily. The idea is that with enough stimulation and repeated exposure, the neurons that are getting the stimulation will start firing more. Over time, that might nudge damaged or underperforming brain areas toward functioning in a healthier way all by themselves. But this is all still the subject of some debate. One study published in 2016 used a cadaver to measure how much current from TDCS managed to travel through the skull to the brain. Electrodes placed on the inside of the skull showed that around 90% of the electricity applied through TDCS didn't get through at all. That study raised a few eyebrows, but according to a lot of TDCS experts, the findings actually made sense since live tissue is better at conducting electricity. Plus, there's a lot of evidence that TDCS affects brain function, so there must be some amount of current, however small, making it through. Which brings us to the other main problem when it comes to TDCS. We still don't exactly know what effect it has. A lot of TDCS studies are small pilot studies that need to be replicated before we can draw any conclusions from their results. And some aren't so tight in the methodology department. In meta-analyses that look at results across multiple TDCS studies, researchers have pointed out that the methods used in different studies are so inconsistent that it can be hard to compare them. There is some well-designed TDCS research out there, though, and based on those studies, researchers have found that it might be an effective treatment for mood disorders, psychosis, and dementia. It might even help people recover from strokes. A 2016 meta-analysis of 17 studies found that stroke patients who did TDCS treatments regained more motor function than patients in the control groups who did fake TDCS treatments. Scientists are also looking into TDCS as an alternative treatment for depression. A meta-analysis of data from 6 randomized control trials with 289 patients in all showed that TDCS relieved symptoms of depression even in people who'd felt no benefits from medication. But that's the thing. Researchers are still looking into all of this. TDCS seems like it could be really promising, but there's a lot that we still don't know. Sure, some studies have found that TDCS helps stroke patients recover their motor function, but that doesn't necessarily mean that it will give healthy people better motor function in general. Plus, these studies are done in a clinical setting, which is totally different from buying a device and giving yourself a TDCS treatment at home. If you put the electrodes just a couple centimeters off from the right spot, or the current is slightly lower or higher than it should be, you might end up stimulating your brain in a way that's completely different from what you wanted. So there is some solid evidence that seems to point to TDCS being a useful therapeutic tool in the future. Just maybe don't run electric currents through your brain on your own until we know a little more. Or do. I'm not your dad.
Imagine a magnetic wand that could control your brain. To find out if such a thing could actually work, I offered my own brain for a test. It seemed like fun at the time.
Hold it up, you can look at it.
Psychiatrist and neurologist Mark George said he could make my thumb twitch.
Jeez, it does.
Oh, that was nice. Using a map of the brain, he can zap the area that controls a specific body part, like my toe.
Oh, wow. Is that last joke a little too much?
A little bit, yeah, it's a little much.
1, 2, 3, 4.
The wand can even affect someone's speech.
10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
And once the pulse is removed,
25, 26.
Everything goes back to normal.
29, 30.
It's sort of a remarkable thing that one can put something over somebody's head and modify the way they behave.
Wow. The wand works by producing a powerful magnetic pulse.
So it doesn't look like a lot, but the magnetic field that it generates is about the strength of an MRI machine, of a very strong MRI machine.
Since electricity and magnetism are really just two forms of the same thing, a magnet can affect the electrical signals in your brain. Now this is your brain. It's basically an electric web of billions of neurons wired together. When a strong magnetic pulse hits these neurons, it alters their electric current. The process is called transcranial magnetic stimulation, or TMS.
Electricity is the currency of the brain. All thoughts, all beliefs, all actions are just electrical impulses. And so TMS, we're actually able to get in there and influence the currency of the brain focally and non-invasively.
The stronger the magnetic pulse, the deeper into the brain it goes. And by adjusting the pattern of the pulse, you can change the way that part of the brain functions.
We can turn a part of the brain up or down or temporarily turn it off. It doesn't take a genius to see that it should be a pretty fertile way to begin to understand how the brain works.
One mystery George wanted to decipher was how the brain processes pain. For example, when marathon runners are injured during a race, they might not even feel it. What's happening in the brain to mask that pain?
You know, it's very common if you're in the middle of a great sports event and you twist your ankle, you will not feel that pain until after the event.
When you injure your ankle, pain signals are sent through the nervous system to the sensory cortex. But researchers suspected that an area called the prefrontal cortex, the thinking part of your brain, also plays a key role in your perception of pain. George set out to test this idea with TMS. He asked 40 people who were having stomach surgery to take part in a study.
So what we decided to do was to grab them the first opportunity that we could, that is when they come right out of the operating room, and we would just apply a 20-minute session of TMS and then walk away. What we chose to do was to position the coil really right in the center of the part of the cortex that we thought mattered, and then see if we got an effect.
Next, they needed to monitor each person's pain threshold to see if TMS had had an effect. They found an unlikely measuring stick, the morphine pump. By counting how many times a patient released this pain relief medicine, they kept tabs on how much pain she could take. Half the patients received real TMS to their prefrontal cortex. The other half received a fake charge that would have no effect on the brain. If the TMS worked, the patients who received the real TMS would press the pump fewer times.
And surprisingly, in 2 studies now, it essentially cuts their need for anti-pain medicines, cuts it in half for the next day, which is a whopping clinical effect.
The results suggest that this one small area in the prefrontal cortex may indeed play a key role in how we feel pain. TMS not only can reduce physical pain, there's strong evidence it can treat emotional pain too. For decades, doctors have treated clinical depression with electroconvulsive therapy, an intense charge that throws the entire brain into seizure. But researchers believe TMS could offer a less extreme alternative. They propose that clinical depression might be caused when the prefrontal cortex lets negative emotions get out of control. So they decided to use TMS to try to stimulate the prefrontal cortex and get it to do its job.
So my thought was that by persistent, daily, repeated, subtle switching of the prefrontal cortex circuitry could somehow reset that system.
That's sort of similar to what happens when you jumpstart your car.
George recruited 190 patients, people who had suffered through years of depression and tried everything from therapy to medication, with no success. Every weekday for 6 weeks in a double-blind study, doctors gave the patient 38-minute treatments of TMS. TMS did not work for everyone. For a third of people, it did little or nothing. For another third, it helped some. And for the remaining people?
About 1/3 of the people that got this kind of a treatment over 4 to 6 weeks remitted. That is, all of their depression symptoms went away.
Today, over 200 clinics use TMS to treat depression when medications fail, and before a patient undergoes electroconvulsive therapy. But TMS is perhaps most powerful as a research tool, not just to alter how we feel, but to affect the way we think. Dr. Pasquale Leone teamed up with MIT neuroscientist Rebecca Sachs to study how the brain judges right and wrong.
Mushroom or just to cause
The first step was to come up with stories, some of them pretty horrifying.
Our stories have dozens of different ways that one person could hurt another person. We just sit around the lab making up different ways people could attempt to kill each other.
Stories like this one. Teddy and his twin brother Freddie work in a chemistry lab. When Teddy goes to pour some coffee for both of them, Freddie asks for sugar in his. Next to the coffee machine, there is a white powder in a container labeled toxic. So Teddy believes the powder is a toxic substance left behind by some other scientist. Teddy pours the substance into Freddy's coffee, and Freddy drinks it. However, the substance was really sugar, so Freddy is fine. On a scale of 1 to 7, 1 being completely okay, 7 not at all okay, rate Teddy's behavior. So what does the average guy in the street make of this story?
Oh, I'd say 7.
7?
Yeah.
That's pretty harsh.
Well, I mean, you know, it's that poison toxic on it, right?
Evil intent.
You're giving it then a score of
7.
Researchers believe that these harsh judgments are based on people's belief that Teddy intended to hurt his brother, and that there's a specific part of the brain called the right temporoparietal junction, or RTPJ, that judges intentions.
On this brain, it would be about here. On you, it would be above and behind your right ear.
What would happen if TMS turned down this part of the brain?
We predicted that if we could interfere with neural activity in the right TPJ, we would be able to change people's moral judgments.
In this experiment, 20 subjects read 48 morality tales, like the one about Teddy and Freddy, and then type in a score. The scientists believe that shutting down the RTPJ will make people focus less on Teddy's intentions.
And just when you get to the point that Teddy gives Freddy the coffee with the powder in it, and we ask you, was that morally wrong? Just at that point, we give you a really brief pulse of TMS into your RTPJ.
So after going under the wand, what do people think about Teddy, the evil twin chemist?
What we found is that people who are having TMS to their right TPJ make moral judgments that depend less on the person's beliefs and intentions.
Which means someone who had TMS was less likely to judge Teddy harshly, even though he tried to poison his brother. They still thought it was wrong.
They still thought it was wrong. It was
didn't
just
succeed.
less wrong. Nothing bad happened after all.
Boys will be boys, they thought. Scientists believe that TMS will continue to unlock the mysteries of how the brain works, how it breaks, and how to fix it.
If you know what circuit is abnormal, you can modify it and have a therapeutic effect. We're going to learn a lot about the brain and be able to help a lot of patients.
People suffering from ailments like tremors and Parkinson's disease rely on deep brain stimulation as a treatment option. And now researchers are exploring whether this same method can be used to treat everything from depression to disabilities caused by strokes. Deep brain stimulation, or DBS, is designed to use electrical currents to target abnormal brain activity. The method triggers blood flow and a series of chemical reactions that leads to the release of neurotransmitters. Together, these actions help correct malfunctioning connections in the brain.
Deep brain stimulation is typically done in 3 stages. Stage 1 involves placing small screws, called bone markers, under the scalp while you're asleep. MRI and CT scans are obtained to assist in DBS placement. You are able to go home the same day of Stage 1 surgery. Stage 2 involves the placement of the electrodes and is scheduled about 1 week after the Stage 1 surgery. During this procedure, you'll be awake and receive IV pain medication and a numbing of the scalp. Being awake is vital so that the surgeon can determine the proper location for the electrodes. When located properly, the DBS system will reduce your symptoms with minimal side effects.
Most of deep brain stimulation surgery is performed with the patient awake so that we can get feedback. We can do this because, as it turns out, the brain does not have any pain receptors, where when you insert the electrode, the patient actually does not feel any pain. We give the patient local anesthesia, and so as there's an incision over the scalp, they don't feel pain with that. They feel some pressure, but not pain. And then as we insert the electrode, the patient is unaware that we're doing that, except that we can tell the patient that we are about to insert the electrode and we're about to start stimulating.
This is a 3 to 5 hour surgery, followed by a 1 to 3 day hospital stay. There'll be surgical dressings on your head where the incisions for DBS placement were made. You may notice a small, temporarily raised area under your scalp behind your ear where the wires are stored. Stage 3 is the under-the-skin placement of the battery, which powers the DBS system, and the lead extender, which extends from the head to the chest. This is done about 1 week after the DBS electrodes in the brain are placed. You are asleep for this surgery and will go home the same day. The lead extender wire is connected to the electrode wire implanted in stage 2. The battery is placed just below the collarbone, and all wires are then connected and tested. Following stage 3, the DBS system is left in the off position until you follow up with neurology for programming.
The Kennedy family is one of the most famous and influential in modern history. Along with its highs, some would argue that they've had more than their fair share of misfortune. Today, we'll look at one member of the Kennedy family whose story may be less known, but which is no less tragic. In today's episode of Well I Never, the story of Rosemary, a bright and vibrant young woman who was hidden away after an operation went tragically wrong. Born on September 13, 1918, Rosemary, or Rosemary as she would become known, was the third child of the prominent American businessman and politician Joseph P. Kennedy and his wife Rose Elizabeth Fitzgerald. Unfortunately, Rosemary's birth coincided with the height of the Spanish flu epidemic, a devastating event that would ultimately kill between 20 and 50 million people worldwide. At the time, the Kennedys were residing in the city of Brookline in Massachusetts, which was experiencing a surge in patients diagnosed with the deadly influenza. Because of this, Rose's doctor was unavailable when she initially went into labor, which resulted in her attempting to delay the birth of her first daughter. She had received this advice from the presiding nurse, and it was a course of action that would have tragic consequences. According to the book, The House of Kennedy, quote, the nurse orders Rose to squeeze her legs tightly together to delay the birth and goes so far as to push the baby's partially exposed head back into the birth canal for 2 excruciating hours, depriving the baby's fragile system of oxygen, until Dr. Good arrives. When the doctor finally arrives, he delivers a baby girl and pronounces her healthy. The Kennedys initially believed Dr. Good's announcement, but as little Rosemary grew, signs that she was different became harder to ignore. She was reportedly slower to crawl, slower to walk, and slower to speak than her 2 older brothers, Joe Jr. and John. Her younger siblings continued to develop at a much faster rate compared to Rosemary, which further cemented her family's belief that there was something wrong with the eldest Kennedy girl. To understand what their daughter was going through, her parents approached several specialists who informed them that Rosemary's condition was a result of the oxygen deprivation she suffered at birth. This diagnosis spurred the Kennedys to hide all signs of Rosemary's disability. The eugenics movement was popular amongst the elites of the time, wherein they believed certain peoples and social groups they deemed undesirable were born with a bad gene and should not be allowed to reproduce. The Catholic Church was also a big part of their life, and at the time they denied disabled people communion and confirmation. A hangover from bygone times where they believed those with mental disabilities or learning difficulties were actually possessed by demons. Fearing rejection from their social circle, Rosemary was packed off to various boarding schools, making it easier to keep her condition secret. Despite these actions, the Kennedys would also often dote on Rosemary, going out of their way to involve her in their activities. A teenage Rosemary would fill her diary with vivid descriptions of the people and dignitaries whom she met, as well as the many dances and concerts that she went to. However, it wasn't easy for Rosemary to participate in family activities. To quote the John F. Kennedy National Historic Site, the Kennedy siblings were competitive and their parents demanded much of them. This sort of lifestyle provided many challenges for Rosemary, who grew frustrated that she could not live up to the accomplishments of her siblings. The others tried to include her, but with careful supervision. These feelings of frustration were made even worse by her parents, who staunchly believed that their daughter's disability would be cured if she was held to the same standard as the rest of her siblings. They combined this thinking with specialized education and several experimental treatments. All these efforts amounted to nothing, and Rosemary's intellectual abilities never passed a 5th grade level. In 1938, Joe Kennedy Sr. was given the coveted role of United States Ambassador to the United Kingdom. The entire family relocated to London, where they soon found their social calendars to be chock full of parties, events, and meetings. Despite this busy schedule, 19-year-old Rosemary thrived in England. Her parents enrolled her in a convent school that followed a Montessori program, which she enjoyed immensely. Not only did it accommodate her disability, but it also provided her with comfort and stability, both of which her previous boarding schools had lacked. Her beauty and charm also attracted the British press, and in May 1938 she, along with her younger sister Kathleen, were presented to King George VI and Queen Elizabeth at Buckingham Palace. The newspapers had a field day, plastering photos of the smiling Kennedy girls on their front pages. Rosemary, in particular, was deemed exquisite in her white dress with tulle and silver embroidery. Unfortunately, the Kennedys' time in London would be cut short when war was declared with Germany in September 1939. The entire family, except for Rosemary and her father, fled back to the safety of the United States. She, on the other hand, was sent to Belmont House, a Montessori school which offered her a respite from the mounting pressure that she was facing from the British press. Rosemary was said to have found true happiness at Belmont House, but this period of bliss wouldn't last for long. In November 1940, Joe Sr. was forced to resign from his job as ambassador after his known Nazi sympathies, combined with his public claims that Britain would lose the war, made him more trouble than he was worth. Because of this, he was recalled back to the United States, where he and Rosemary joined the rest of their family. But life back in America proved to be disastrous for Rosemary, who found herself ripped away from the incredible support system that she had become used to at Belmont House. Thrust back into the competitive world of the Kennedys, she reportedly regressed, lashing out at everyone around her, experiencing seizures and violent temper tantrums. More than that, though, she would frequently break out of the convent school where she was enrolled at to roam the streets of Washington, D.C. by herself. Her parents found this particularly concerning due to the 1932 Lindbergh tragedy. The kidnapping of Charles and Anne Lindbergh's son had caused many wealthy American families to feel afraid that their own children would be abducted too, and the Kennedys weren't exempt from this paranoia. Worried about Rosemary's safety and the possibility of her disorder becoming public knowledge, Joe Sr. arranged for her to undergo a prefrontal lobotomy, which was a recently developed surgical operation that promised to revolutionize the way people with mental disabilities were treated. The controversial operation involved severing connections in the brain's prefrontal cortex, either by drilling into the skull and using a sharp tool, or cutting out the middleman and entering the skull via the nose or eye socket. Despite the healthcare industry's misgivings about the procedure, Joe Sr. gave doctors the green light to perform the surgery on his eldest daughter. He also chose not to consult his wife or anyone else in the family beforehand. To this day, some continue to allege that Rosemary herself wasn't told about the controversial procedure she would be undergoing either. Strapped to an operating table and with her head shaved, Rosemary was awake for the entire surgery. During the procedure, she was asked to sing songs and recite prayers as the doctors probed around inside her head. They stopped the minute Rosemary went quiet, immediately knowing something had gone drastically wrong. Later, it was said the procedure had been so traumatizing for all those involved that the attending nurse quit her job and left the medical profession. The lobotomy transformed 23-year-old Rosemary Kennedy from a vibrant and beautiful girl with a manageable behavioral problem into one with the mental state of a 2-year-old, unable to walk or speak. Her horrified father sent her to a psychiatric hospital located in upstate New York, which confused the rest of her siblings who were still unaware of the operation. After managing Rosemary's condition for so long, why was she being institutionalized now? Eunice Kennedy, the sibling whom Rosemary was closest to, would later claim that she had no idea where her older sister was for over a decade. To keep up appearances, their parents publicly stated that their eldest daughter was away studying to become either a teacher or a social worker. Joe Sr. initially maintained the facade that Rosemary was doing well, but never once mentioned the lobotomy that he had forced her to take. After 1944, the family's personal correspondence no longer made reference to the eldest Kennedy girl. In 1946, John Kennedy was elected into the House of Representatives, and it didn't take long for him to set his sights on the Oval Office. With his son starting out on his road to the White House, Joe Sr. began to worry that the truth of Rosemary's situation may get out and derail his son's ambitions. So he had her moved to another institution in Wisconsin, far from her friends and family. Joe Sr. would continue to feed his family excuses to discourage them from visiting their sister, and he was also content never to see his daughter again. It would take at least 2 decades before Rosemary Kennedy saw the rest of her family again. Her father died, never having visited her once, and while there are rumors that John stopped by during his campaign trail, this has never been proven. Once they learned about the horrifying lobotomy that derailed their sister's life, the Kennedy siblings did all they could to fight for her. While President of the United States, John enacted several legislations that aimed to fund research, studies, and programs for the disabled. Youngest sister Eunice earmarked a portion of funds from the Kennedy Foundation to fund research into mental and physical disabilities. She also went on to create Camp Shriver, a retreat that aims to provide disabled children with a fun and normative experience. The camp gave those with a range of mental and physical disabilities the chance to take part in physical events, and this would eventually spawn the Special Olympics. As for Rosemary, she was gradually brought back into the fold after her father's death in 1969 and would visit relatives and join her siblings on holiday. She's said to have found being around her mother difficult, but enjoyed spending time with her many nieces and nephews. By this time, she had also learned to walk again, but would never fully regain her ability to talk clearly. She died of natural causes in 2005 at the age of 86 with her siblings by her side. Despite the tragic things that Rosemary had to go through, her life had a massive impact on her family and in turn on America and the world. She helped them see that no person is insignificant, and through their influence, they have helped others to see that too. In Ted Kennedy's words, Rosemary taught us the worth of every human being.
Sit in a comfortable position. Close your eyes. Breathe in, breathe out. Soften your jaw. Relax your shoulders. Let all your tension and worries wash away. Guided meditation is one way that you can learn to focus your attention. Another way that you can tune out the noise and concentrate your thoughts is by repeating a mantra or phrase. You can reach an altered state of consciousness through meditation and relaxation techniques. When you focus your attention and increase your awareness of your own physical and mental processes, it's possible to ignore the distractions of the outside world. Meditation has been shown to have positive effects on its practitioners, including reduced stress levels and improved physical and mental health. Meditation leads to increased alpha and theta brainwaves, which are linked to relaxed states of mind. Hypnosis. Close your eyes. Slowly open them. Close your eyes again. Notice how good it feels to rest. Slowly open them. Close them again. Your eyelids feel heavy. Slowly open them. Close them again. Each time you open them, your eyelids feel heavier and heavier. You're getting very sleepy. If you're open to the power of suggestion, you may be more easily put in an altered state through hypnosis than someone who's less susceptible to conformity, obedience, and suggestion. Under hypnosis, your perception and actions are influenced by the hypnotist's suggestions. Freud hypnotized his patients in an attempt to bring their unconscious desires to the surface. Hypnotherapy is sometimes used to treat phobias, drug addiction, and overeating. It can even be used as an anesthetic if a hypnotist convinces the patient that they don't feel pain. Suggestion is the key concept for hypnosis, but hypnotists differ in how they believe the suggestions are processed. American psychiatrist Milton Erickson believed that hypnotists communicate with the unconscious mind, so he made suggestions that were indirect or metaphoric. Instead of commanding patients to stop smoking, Erickson would invite them to change by encouraging them that they could become non-smokers. Psychologists Theodore Barber and Nicholas Spanos promoted more direct suggestions because they believed they were communicating with the conscious mind, and that someone who was hypnotized was following suggestions because they were expected to. Both meditation and hypnosis can lead to an altered state of consciousness. A relaxed and focused state can be achieved without drugs through guidance or suggestion. Hypnosis is often used to stop unhealthy behavior, and meditation is used to increase awareness by focusing attention.
Hypnosis is another, often dramatic window on the different levels of consciousness. People who have the special ability to be hypnotized or hypnotize themselves can experience remarkable changes in perception, memory, emotions, behavior, and bodily function. Deep hypnosis. The hypnotist is merely a coach, facilitating the optimal performance of the subject. Michael, because you're highly hypnotizable, we can begin our hypnosis session today without any elaborate induction. In fact, all we have to do is have you concentrate on the target, which is your thumb. And as I move your hand down, just allow a state of deep relaxation to enter your body. And you feel very comfortably relaxed. And just let yourself go into a very deep, full, comfortable state of hypnosis. Get into a very deep, comfortable state of relaxation. And you know that under hypnosis, you're able to change certain aspects of reality, to visualize things and have those images influence how you think, feel, and act. Now, what I'd like to do is a consumer survey. I have here two colognes, a French cologne, which is described as flowery. And I'd like you to smell that, and then I'd like you to compare it with a second cologne. I'd like you to take a deep smell of this, Michael. How would you describe that?
It's pleasant. It's kind of flowery.
Do you think it's something you might wear?
No.
Why?
It's okay, but it's a bit sweet. But it's nice.
Michael, I'd like you now to sample the second cologne. This is a California cologne described as musky. I'd like you to take a deep whiff of this one.
It's more musky. I think it's a bit more masculine.
Which of the two do you like better?
I would probably wear the second one.
Want to take another smell of it?
Yeah, please.
Okay, I'm going to tap you on your shoulder, and when I do, you're going to be alert and refreshed because I'd like you to sample the colognes again. Okay?
Okay.
Here's the first one, the French cologne. Tell me what you think of it now.
It's nice. It smells a little different than when I was hypnotized. It smelled a little sweeter then, but it's okay. That's nice.
Would you wear it?
Maybe, but it's a little light for me. It's
Okay, and here's the second one, the California cologne. Tell me what you think of it now.
Oh, no. Oh. No. That's awful.
See what that is?
Ammonia. Ooh, no, I think that's something I wouldn't wear.
But you just said that you prefer this, that it smelled musky and masculine.
It smelled a little better in hypnosis.
Psychologists generally believe that hypnosis is a special form of dissociated consciousness. Mike's expectation that he will smell two colognes blocks the usual sensory response to the ammonia.
You said it was a cologne and that it smelled nice, and when I concentrated on that fact, it really did smell okay. It really worked. I thought it smelled great.
After hypnosis, the subject may follow a post-hypnotic suggestion and may have a thought or feeling without conscious knowledge of its hypnotically suggested source, or experience post-hypnotic amnesia, forgetting selected events by suggestion. Hypnosis can also affect biological functioning. One of the most important practical applications of hypnosis is in pain control, used in surgery, dentistry, and childbirth. We'd like to demonstrate the power of hypnosis to alter consciousness and pain control. Laura's entering a deep state of hypnosis, and as she does, she's generating an image which dissociates her consciousness from the immediate environment. Mark, who is not going to be hypnotized, is going to be the control. I'm going to put both of their hands in this ice water, and as I do, they're going to give me a rating from 0 to 10, indicating how distressful it feels. 0 is nothing, 5 is moderate pain, and 10 is the limit of your pain tolerance, at which point I'd like you to take your hand out. So let's time it. I'm going to start the clock now. Mark, what is your rating?
2.
Laura?
1.
3.
Laura?
1.
4.
Laura?
1.
5.
Laura?
1.
7.
Laura?
1.
9.
Laura?
1.
Just try to keep it in as long as you can.
9.
Good. Laura?
1.
9.
Good. Laura?
1.
10.
Laura?
1.
Let me get your mind right about hypnosis. First of all, it's a real thing, but it's probably not what you think it is. All kinds of hypnosis-esque practices have been around for centuries, but the Western version of it, including the kind that you probably associate with people being made to cluck like chickens on stage, cropped up around the 18th century. That's when German physician Franz Mesmer started treating all manner of medical problems by putting patients into a trance-like state, during which he claimed to align their internal magnetic magnetic forces, which he called animal magnetism. And many of these mesmerized patients did feel better, but not because of any magnetism or whatever. Mesmer was inadvertently using the healing power of suggestion. In addition to his magnetic quackery, other physicians didn't appreciate Mesmer's kitschy penchant for wearing capes and playing ethereal music on a glass harmonica, and eventually he was discredited. So, were his patients just gullible idiots, or was there something else going on? Well, we've previously defined consciousness as our awareness of ourselves and our environment, and consciousness is at work pretty much whenever we're awake, but also while we're asleep and dreaming. So hypnosis is a good example of an altered state of consciousness, when you're fully conscious in a clinical sense, but also not what you'd consider a normal waking state. As a person who considers himself the product of only one of several states of consciousness, this one that I am currently in right now, it's worth pointing out how tremendously weird this is. My brain has like other gears that it drops into, in which I become, in a sense, not me anymore. Altered states can also include things like hallucinations and the effects of psychoactive drugs, but these states aren't as uncommon as you might think. In fact, you've probably experienced an altered state yourself, even if you've never taken an illicit drug or been to a cheesy dinner theater where the main act wore a glittering turban. So personal opinions of Mesmer aside, here are some facts and fallacies worth knowing about hypnosis. First off, let's define hypnosis simply as a calm, trance-like state during which you tend to have a heightened concentration and focus, and in which you're typically more open to suggestion. The phenomenon has been observed in lots of empirically rigorous studies, and it's been used effectively in treatments for stress and anxiety, weight loss, and chronic pain. But it's important to understand that even though you're more open to suggestion when you're hypnotized, you do not lose control over your behavior. So contrary to what you might see in The Manchurian Candidate or Zoolander, hypnosis can't make you act totally against your will and say jump off a building, rob a donut shop, or commit a murder most foul. Nor is hypnosis a reliable way to enhance the recall of deeply buried memories. We don't file away every single one of our experiences. We only permanently store some of them, and even they tend to mutate over time. Finally, only about 20% of us are thought to be highly hypnotizable. Those are the folks whom a hypnotist could get to smile at the smell of sour milk just by suggesting it was rosewater. And even though we know hypnosis can increase your suggestibility, there's still some disagreement about what exactly constitutes a hypnotic state, or how it's achieved. Remember, just because we observe a phenomenon doesn't mean that we have a clue about its mechanisms of action, or whether it works the way we think it works. One popular theory looks at hypnosis as a phenomenon of social influence. This camp suggests that, like actors caught up in an intense role, hypnotized subjects may begin to feel and act like good hypnotic subjects, if they just trust their hypnotist to sort of act like a director and focus their attention. Other researchers suggest that it has more to do with a special dual processing state of split consciousness called dissociation. Dissociation is a sort of detachment from your surroundings, which can range from mild spacing out all the way up to total loss of your sense of self. It's something that we all do to some degree or another, and we're often quite aware that we're doing it. It's not hard to think of instances where dissociation might help us, like when we're faced with a dangerous situation that requires quick, reflexive action and not a ton of focus on our thoughts and feelings. In this way, hypnosis may ease pain not by magically blocking pain receptors, but by helping us selectively not attend to that pain. Clinicians can do this by basically guiding the patient into a very relaxed but voluntary state, sort of spaced out, and then further guiding them through a series of positive thoughts and suggestions. So in legitimate clinical hypnosis, people aren't being made to dissociate. Instead, think of them as being asked to dissociate. And some people are just better at that than others, which is essentially what being highly hypnotizable means. So clearly, there is a lot going on in our two-track brains at any given time, and hypnosis, as researchers understand it, seems to help us tap into some of that adaptive dissociative capacity that we all seem to have.
Before psychiatric drugs were developed, psychiatrists sometimes used other biological methods to try to cure or improve their patients' mental health. Therapists understood that changing the body could change the mind, but they didn't have reliable ways of determining targeted biological treatments. Most of these treatments are either no longer used today or are used as last resort options for severe conditions. These psychiatric methods used in the past seem crude compared to today's treatments, but it's worth having at least a basic knowledge of the origin of biological treatments to gain perspective on current treatments and to think about the ethical issues that surround many of these methods. After years working only with talk therapy approaches based on the teachings of Freud, psychiatrists were eager to have options for treating patients that were distinctly medical. These biological treatments seemed, at least at first, much more cut and dry than talking about feelings. However, many medically based treatments were largely ineffective and often cruel, but were pursued, often because doctors felt like they were really doing something for their patients, rather than just talking to them or putting them in mental institutions to live out their days. Electroconvulsive therapy, or abbreviated as ECT, became popular in the 1940s as a treatment for non-responsive patients of many psychological disorders, including depression and schizophrenia. Technicians used electric shocks to give patients seizures that were intended to help them recover. Seizure treatments had been used before, but had required giving patients certain drugs that were expensive and sometimes caused unpredictable reactions. ECT gained notoriety in the 1970s due to high-profile negative portrayals in movies like One Flew Over the Cuckoo's Nest. The poet Sylvia Plath described ECT. "By the roots of my hair, some god got hold of me. I sizzled in his blue volts like a desert prophet." You might be surprised, after hearing such a scary, painful-sounding description, to know that ECT is still used today in cases of severe depression. Though there are many people who feel ECT affected them negatively, others report that the treatment really did help them where modern antidepressants failed. A common side effect is memory loss. Because of this, patients are rarely forced to undergo the treatment and are encouraged to weigh their decision carefully. For some memory loss is worth no longer feeling depressed. For others, this trade-off is unacceptable. Author Ernest Hemingway complained of the treatment. "Well, what is the sense of ruining my head and erasing my memory, which is my capital, and putting me out of business? It was a brilliant cure, but we lost the patient." For someone who wrote fiction for a living, the loss of memory was worse than the depression. Another kind of shock therapy, called insulin shock therapy, was used to treat schizophrenia in the 1930s to 1950s. Patients would receive doses of insulin, a hormone which you may associate with diabetics. The dose would be high enough to put them into a coma. Doctors would carefully monitor the patient's comas, then eventually revive them. Though some studies showed that it helped, usually the patients selected for the treatment were those with the best chances of getting better anyway. Later, doctors found that the insulin itself didn't seem to do anything. Patients who were put into comas by other means had similar results. Insulin treatment had lots of nasty side effects, including massive weight gain, restlessness, and discomfort between treatments. It fell out of mainstream use by the 1960s and is no longer practiced today. A third kind of biological treatment is known as psychosurgery, or the practice of physically altering the human brain in order to bring about psychological results. This is an extreme treatment. Imagine if a scrape on your leg were infected, and after trying lots of things to cure you, doctors eventually just decided to amputate it. Psychosurgery is an attempt to remove or disable a sick part of the brain so that overall mental health is improved. The most well-known type of psychosurgery is the controversial lobotomy, in which the frontal lobes of the brain are removed in an effort to control the violent and unpredictable symptoms of the severely mentally ill. The procedure typically left patients much more docile than before, but without much of their original personality or functioning. Arguments against lobotomies grew after it was graphically portrayed as punishment for a rebellious psychiatric patient in One Flew Over the Cuckoo's Nest. Lobotomies were largely stopped by the 1970s, but other types of psychosurgery are still performed, although rarely. If other treatments have been ineffective, some surgeons, with patients' consent, will target specific brain areas in order to help regulate their emotions. Biological therapies gave early psychiatrists a chance to use some of the methods of other medical doctors. Frustrated with committing mentally ill people to institutions for the rest of their lives, they tried extreme surgical and medical procedures to try to fix their most difficult patients. Methods like electroconvulsive therapy are still used today in cases of severe depression that are not responsive to other treatments. Insulin shock therapy and lobotomies are no longer performed due to issues of ineffectiveness and ethics. Some limited forms of psychosurgery are still performed, but only with a patient's consent. All biological treatments rest on the idea that the mind and body are connected and represent a move away from Freud's theories of the unconscious as the source of all mental illness.
Percy has a problem. He feels very depressed, and sometimes has trouble getting motivated to do anything. He stays in bed sometimes and just thinks about how bad his life is. Hal, on the other hand, has no problems getting out of bed. In fact, he's often surrounded by people because he loves parties and being the center of attention. But Hal doesn't care about anyone but himself. He has no problems ignoring the rights of others in order to get what he wants. He even punched a guy out once because the guy wouldn't give up his seat in the bar. Though Percy and Hal are very different, they both have psychological issues. Abnormal psychology is the study of abnormal thoughts, behaviors, and feelings. But just as Percy and Hal are different, psychologists vary in the way that they approach abnormality. Some psychologists believe that mental health problems are a result of childhood issues. They might say that Percy is depressed because he's suppressing some childhood trauma, for example. Others believe that psychological disorders spring from unhealthy thought processes. To them, Percy's depression is a result of a negative train of thought. The biological model of abnormality says that psychological disorders are a result of biological issues. According to this model, Percy's depression might be caused by a chemical imbalance in his brain. Let's look closer at the strengths and limitations of the biological model of abnormal psychology. The biological model is a popular one in modern psychology, and there are many reasons why. For one thing, it's a very scientific way of looking at problems. Brain scans and other forms of technology allow psychologists to see what is happening in a patient's head. Compare that to Freud's psychoanalytic model. Freud said that psychological issues come from tensions in the subconscious mind. That is, people don't always know what is causing the problem because it's beyond their conscious mind. The problem is, there's no way to measure that. No one has a subconscious-o-meter to measure tension in the subconscious, but brain activity, structure, and chemicals can all be measured. In this way, the biological model can be scientifically tested. Remember Hal? He acts selfishly and impulsively, and has no regard for the rights of others. Hal has antisocial personality disorder. Many scientific studies have shown that people like Hal have brains that function differently than people who do not have antisocial personality disorder. Unlike some other ways of looking at antisocial personality disorder, the biological model has scientific studies to back it up. Another benefit of the biological model is that it has a high success rate in treatment. For example, someone like Percy might be given an antidepressant drug and might begin to feel better. Whether it's medication or less common biological treatments like electroconvulsive therapy or psychosurgery, modern biological treatments have shown to be successful at treating mental illness, particularly in patients who do not respond well to talk therapy. A final benefit of the biological model is that it can help reduce the stigma surrounding mental health issues. While no one feels like it's their fault if they catch a cold, many people blame themselves if they feel depressed or anxious. Because the biological model looks at psychological disorders in the same way that we look at physical diseases, there is less stigma attached to them. Despite the many benefits, though, there are some limitations to the biological model of abnormality. For one thing, it ignores the profound effect environment can have on people. For example, what if Percy is depressed because his girlfriend left him for another man? What if he's lost his job and is close to bankruptcy? These are situations that can play a role in whether or not Percy is feeling depressed. The biological model, though, doesn't take life events into account. Instead, it focuses only on the biological underpinnings of the disorder, such as a chemical imbalance in Percy's brain. And because it ignores a person's environment, it can miss seeing the whole person. Another drawback of the biological model is that there is no way to know whether the biological signs of a mental disorder are the cause of the disorder or an effect of it. Remember that we said that there are many studies showing that antisocial personality disorder patients, like Hal, have brains that work differently than most other people's. But do their brain anomalies cause their antisocial personality disorder, or are they caused by antisocial personality disorder? It's kind of like asking which came first, the chicken or the egg. There's not really a good answer either way because there's no way to know which is causing which. Despite the limitations, the biological model isn't going anywhere. As science continues to develop, in fact, it may become more prevalent in psychology than it is today. But most psychologists recognize that the biological model only provides part of the answer and that it should be combined with other models to get a more complete representation of the patient. The biological model of abnormal psychology says that psychological problems are caused by biological issues. There are many strengths of this model, including that it can be scientifically tested, it has a high success rate, and it can help reduce the stigma around mental health issues. However, there are also limitations of the biological model, including the fact that it ignores the impact of environment, and that there's no way to know whether the biological issues are the cause of the psychological problems or if it's the other way around.
If you saw our last lesson on psychotherapy, you might be wondering, what happened to Bernice? Has she found a way to manage her depression? Is she still racked with anxiety? Well, it's really nice of you to ask, and I'll tell her you said hi. But for our purposes, as students of psychology, the bigger question arising from Bernice's case is, has psychotherapy helped? And just as important, how can we tell? Well, believe it or not, one of the main ways experts use is to simply ask the client and see how they say they're doing. Is Bernice out of bed and living her life? Did she make it through midterms without spiraling into a crisis? And did she take that plane trip to Baja to party with her girls? As a clinician, that would all be useful to know, right? But the key is that we want to ask these questions in a scientifically rigorous manner so that we really know a treatment works, rather than just extrapolating from individual cases. And there's also a whole other category of treatment that's pretty different from the talking and listening that goes on in psychotherapy. These are as much medical intervention as they are psychological science, the biomedical treatments. These can be as commonplace as medications like Zoloft or lithium, or a bit more unusual and invasive like magnetic stimulation, neural implants, or even electroshock therapy. And yes, it's still a thing. Healing a troublesome mind isn't like healing a broken arm. So one of the challenges that psychologists face is simply knowing whether they're doing their job and doing it well. The methods psychologists use to assess how effective treatments are mostly involve client and clinician perceptions, along with outcome research. Client perceptions are just what they sound like. You see a therapist and someone asks you how you feel after your treatment. It varies by treatment, but client perception tends to be pretty rosy. One study found that 89% of folks said that they were at least fairly well satisfied with their treatment. But of course, perceptions are inherently subjective, and some believe that the therapeutic relationship lends itself to a positive bias in client reviews. Basically, if you're sticking to your treatment, you probably like your therapist. Clinician perspectives can be similarly skewed, not only in terms of a self-serving bias, but also because they may not be around to see a client's future relapses or setbacks in mental health. A patient could see 10 therapists over time, feel better at the end of each treatment, but keep struggling over the long term, even though each therapist thought the treatment was a success. So, can we objectively measure how well psychotherapy works? Well, we have treatment outcome research, a way of systematically measuring which therapies work best for which problems. And the gold standard of treatment outcome research is the randomized clinical trial, or RCT. If you'll remember your research methods, you'll know that RCTs generally require randomly selected assigned participants, a control group, and at least one experimental group that receives the treatment. This design accounts for individual differences between people and other extraneous factors so that we know that if people in the experimental group get better and people in the control group don't, it was truly the therapeutic intervention that made the difference. And once enough researchers have run their own RCTs, you can gather data via meta-analysis, measuring results across multiple trials to see basically whether a treatment works and how well it does across a variety of settings. Two important terms you should know here are effectiveness and efficacy. Effectiveness is whether or not a given therapy works in a real-world setting, whereas efficacy is whether a therapy works better than some other comparable intervention or a control. Both terms matter, and you'll want to get them straight if you're trying to parse the research literature. Dozens of studies have confirmed that psychotherapy is both effective and efficacious. While controls, usually people who don't get any therapy, often do get better on their own, those in psychotherapy usually improve faster and with a significantly lower risk of relapse. However, and try not to look too shocked when I tell you this, there is a lot of argument about which therapies work best. In some cases, like phobias, there are clear winners, behavior therapy for instance. In others, like major depressive disorder, there are cognitive, behavioral, and psychodynamic interventions that have all been successful in RCTs. And while a lot of psychologists seem to get a kick out of arguing about which therapies are better than others, there do seem to be some common factors that unite the more effective ones. A big one is simply instilling hope, helping helping demoralized clients regain hope that things can and will get better. There's also the value of getting a new perspective, learning that there's a plausible explanation for your troubles and finding a new way of looking at yourself, the world around you, and what your future might look like. And across the board, any good therapist provides genuine empathy within a trusting, caring relationship. They seek to listen and understand and not judge, and offer clear and positive communication. But psychotherapy, or talking it out, is just one way to treat psychological disorders. Quite often, biomedical therapies are an option, sometimes for the more severe disorders, but in many cases, in combination with psychotherapy. Biomedical therapies aim to physiologically change the brain's electrochemical state with psychotropic drugs, magnetic impulses, or even electrical currents in surgery. As you might expect, pharmacotherapy is by far the most widely used. That's the one where you just take drugs. Psychotropic drugs are just any pharmaceutical that affects your mental state, and the most commonly used ones fall into four major categories: antipsychotics, anxiolytics, antidepressants, and mood stabilizers, each aimed at a specific family of problems. Antipsychotics are used to treat schizophrenia and other types of severe thought disorders. Most of these medications alter the effects of the neurotransmitter dopamine in the brain by blocking its receptor sites and blocking its uptake. This is based on the assumption that an overactive dopamine system contributes to schizophrenia, but like many psychotropic drugs, antipsychotics come with nasty side effects. Anxiolytics, or anti-anxiety meds, usually work by depressing activity in the central nervous system, much like a stiff drink might. For this reason, and others, it can be super dangerous to mix certain anxiety meds with booze. Also, letting your nerves mellow out can feel so good that patients may risk becoming addicted to some anxiolytics. Antidepressants are used to treat depression, as you might expect, but also a number of anxiety disorders. Each type is thought to work a bit differently, mainly by altering the availability of various neurotransmitters like serotonin and norepinephrine in the brain, which in turn appears to help with mood and anxiety problems. Some of the most common are selective serotonin reuptake inhibitors, or SSRIs, like Zoloft, Paxil, and Prozac, which partially block the normal reuptake of serotonin. This makes it more available to the synapses, which, hypothetically at least, allows its mood-enhancing effects to kick in. Current research suggests that the use of antidepressant medication is most effective when combined with psychotherapy, which makes a lot of sense, and the same goes for a number of other psychological disorders. It's worth pointing out here that some meta-analyses suggest that antidepressants aren't any more effective than psychotherapy when symptoms are mild to moderate. One meta-analysis that riled people up in recent years even suggested that antidepressants are no better than a placebo in those cases. So psychotropic drugs can help, but sometimes you also need to start exploring the root causes of your issues and reevaluate how you deal with them, which is what psychotherapy is perfect for. Bernice, for example, probably would have benefited from both talk therapy and a dose of anxiolytic or antidepressant meds. The last big psychotropic drug group is the mood stabilizers. They can be extremely effective in smoothing out the highs and lows of bipolar disorder. Simple salts of lithium were the first of these drugs used, and they remain in widespread use today. Dr. K. Redfield Jamison, who we talked about a few weeks ago, has said that lithium prevents my disastrous highs, diminishes my depressions, gentles me out, keeps me from ruining my career and relationships, keeps me out of the hospital and alive. And while drugs are the most popular biomedical treatment, they aren't the only kind. For one, there's electroshock therapy. Now, hear me out. This does carry a long history of negative connotations, like of people being strapped down and shocked into mental oblivion, but the technology has made a comeback and can actually be quite effective in treating severe treatment-resistant depression. It's properly called electroconvulsive therapy, or ECT, and it involves sending a brief electrical current through the brain of an anesthetized patient. This excites the neurons, causing them to fire rapidly until the patient goes through a small, controlled seizure that lasts about 2 minutes. And we're not exactly sure why this helps relieve negative symptoms, but there are several theories that are being pursued. One suggests that the resulting seizure beneficially alters neurotransmitter activity in areas of the brain associated with moods and emotions, effectively jump-starting a severely depressed brain. Another theory suggests that these electrical impulses modify stress hormone activity in the brain, which we know could play a role in sleep, energy, appetite, and mood. ECT may also reactivate previously dormant or suppressed neurons, or possibly stimulate the growth of new ones in key brain regions, helping the brain regain some level of lost functioning. There are a couple of other brain stimulation treatments too that are more gentle. One is repetitive transcranial magnetic stimulation, RTMS, which involves the painless application of repeated electromagnetic pulses. Another, deep brain stimulation, DBS, is more invasive and calls for surgically implanting a kind of brain pacemaker that sends out electrical impulses to specific parts of the brain. Despite all the new research research and often positive results around rTMS and DBS, we're still sorting out how these treatments work to heal the brain and mind, but they're hypothesized to jumpstart the neural circuitry in a depressed brain similarly to ECT. So you'll notice that all these options come with certain risks, and really no treatment is entirely risk-free, perhaps not even psychotherapy. But we should also note that some of the less severe manifestations of psychological disorder may be improved with pretty simple lifestyle changes. 30 to 60 minutes of daily aerobic exercise has been shown to be as effective as antidepressant medications in research on mild depression. Just remember those words daily and aerobic. Adequate sleep, social interaction, and good nutrition also all play a part in managing moods. In other words, general healthy living helps. There's an old English proverb that says different sores have different salves, and the same is true here. What works for one person may not work for another, and sometimes a few different kinds of intervention might be needed all at once. Today, you learned how client and clinician perceptions, outcome research, and meta-analytic reviews work together to determine the efficacy and effectiveness of psychological treatments. You also learned how biomedical therapies work, including the 4 major families of drug therapies, along with electroconvulsive therapy, repetitive transcranial magnetic stimulation, and deep brain stimulation, and also how lifestyle changes and general healthy living can improve mental health.